Yeah, good morning, everyone. Welcome to the session Head and Neck MRA. Let's begin with the first talk. Let's welcome Dr. Yulin Ge from NYU. His talk titled USPIO Enhanced Cerebrovascular Imaging. Welcome.
Okay, thank you, Chen Chen, for the introduction, and also many thanks to the meeting organizers for inviting me to give this presentation. So my talk is USPIO Enhanced Cerebrovascular MRI Imaging, and we believe the USPIO or the Ferromoxto Enhanced MRI has the potential to become a next generation of the microvascular imaging. The technique used here is called the micro, short for the microvascular in vivo contrast revealed origins. And I will first to introduce several key imaging concepts, followed by imaging the outcome measures it provides. And lastly, I want to discuss its clinical applications and the future potential in the field. So yeah, I don't need, I think, to explain what is the Ferromoxto or USPIO because several talks in the past 2 days already talked on this topic. And but I do want to emphasize that compared to the gadolinium, the contrast agent, the USPIO has a stronger T2 shortening and also bigger blooming effect. And what is the micro? So it basically it's a pre and post USPIO double echo 3D gradient echo. The Ferromoxto dose used here is between 2 and 4 milligram iron per kilogram the body weight. And so at our side at NYU, we used 70 MR for this sequence. And there are several imaging concepts related to this sequence. So one is it is double echo. The first TE acquired like between the 5 and 10 millisecond. This is for the TOF arterial angiogram, and also the second TE, the longer TE, is between 15 and 24 millisecond, is for the SWI venogram. And so we use the T2 based negative contrast, and I'm going to talk more about that later. And also, we know that USPIO is an iron-rich agent can induce the blooming effect. This is also the key imaging concept. So then, when we get the pre and post the contrast, the gradient echo images, we can differentiate the arteries from veins. I can also talk about that later. And the sequence include both quantitative SWI and quantitative QSM from this sequence. So this is the example of the micro. So includes the multi-contrast the images. So the first T is the TOF anteriogram, and also the second T is the SWI for the venogram. And we can see the post SWI and QSM showing largely improved detection of the small vessels. And the most Ferromoxto enhanced studies have been used the T1 weighted imaging, which showed the positive contrast enhancement. So we prefer using the T2 weighted imaging for the negative contrast enhancement that is shown here. So there are 3 reasons for this. First of all, the T2 star weighted imaging has strong the blooming effects, especially for this iron-rich contrast agent. As you can see here, it's very good for the small vessel detection compared to the T1. And the second is the gradient echo can allow the the higher resolution with similar time compared with the T1, and this is particularly useful for the the higher field 70. Another thing is the 70 imaging is preferred for the gradient echo compared to the T1 because as shown in the next slides, we can see here the 70 provides superior SNR resolution and stability contrast for the small vessels. Even these images are pre-contrast. So one of the key imaging concepts, as I mentioned, is the blooming effect. So this is the phantom studies with 10 small tubes. So with one tube containing the saline and the nine tubes with different, the USBL concentrations. These are the images, gradient echo images are quite on the 1.5T and 3T. We can clearly see the tubes with the USPL solutions are much bigger and than the tube with the saline, indicating the blooming effects due to this iron contrast agent. And of course, the degree of the blooming effect depends on the multiple factors, including the magnetic field strength, the MRA sequence you used, either the gradient echo versus spin echo, and also the iron concentration, and also the imaging parameters such as the echo time, spatial resolution, and also the method you use to process the image, such as using the SWI. So we can see here with longer TE, there's the blooming, the effect is bigger. And compared with the TE of 6 millisecond, the TE of 33 millisecond has 3 to 4, the bigger, larger the size. And of course, with longer TE, we can see here in the bottom, the signal to noise is also decreased. This is the downside of longer TE. And this is the example of the vessels showing also the blooming effects with like a more than double the size increase of this small vessel on the post contrast SWI. Of course, with the increase of the concentration of USPL, both the stability is increased and also the vessel size is increased as shown here. And when you look at when you compare the pre-USPO and post-USPO SWI, you see a lot of kind of new vessels appeared on the post the contrast image. Those vessels are mainly the arteries, because we know the arteries, arterial blood has a higher oxygenation level, so it didn't show on the pre-contrast SWI, but it can be present on the post. So this is an example. Also, that one is one way to differentiate the artery and the venous. And also, this is another way to differentiate, because we have the first TE, the short TE on the gradient echo, and we can see the kind of top like the anteriogram showing on the the far left. And we can use that to identify on the post contrast, because on post contrast is all dark, right? We can use that as a reference to identify, so also to tell which one is artery. When you look at this image on the left carefully, the signal intensity on SWI is also slightly different. The veins appears a little bit darker than the arteries after giving the contrast, especially at the lower dose. And also you can see on the right, the graph shows that the stability difference between the venous blood and the arterial blood. The venous blood is the higher stability. But when you increase the dose, actually that difference is getting smaller. And the signal is kind of like more saturated. I think this makes sense because we know the USPL has a strong stability effect. So once we have this kind of the high resolution, the vascular, both anterior and venous, the gram, we call it the MRAV. So we can, get the vascular map or vascular, the architecture print from this using the vascular tracking, as shown in this here, in this image, and this can be used to quantify the vascular density at either the global level or a specific, the brain region. In this case, is the hippocampus. So this work is done by the Saga Buch in the Dr. Hickey's group from the Wayne State. We have been collaborating on the USPO project for 7 or 8 years now. And I think this is the first in vivo mapping microvascular architecture, in these details for the hippocampus, it's quite well matched with the postmortem, the study, pictures on the left. And for the small vessel tortuosity, so there is an unmet clinical need, which is in vivo detection of small arteries. We know the TOF MRA can detect the large arteries, and SWI is doing a very good job in detecting both the large and small veins, but there's no current the good technique in detecting the small arteries, which is like at a micro level at 50 to 200 micron. So we use the USPLO to highlight these small the arteries. Not only we can see the small arteries in the young people, for example, on the left, and also we can see many tortuous small vessels, small arteries in the old people. In this case, actually, it's not that old; it's 51 years old, and this is these tortuous small arteries can only be seen previously on the postmortem. Right now, we can see it in vivo. So I have another, the presentation probably in 1 hour. So I'm not going to talk about this in details, but so we found also the regions that has larger number of the tortuous arteries also have a larger number of the white matter hyperintensity. And this suggests the kind of the strong link, or the kind of tortuous vessels may have an impact in the blood flow in this region. And also the USPLO enhanced MR can really detect the choroid plexus changes with age. Because choroid plexus right now is a hot topic. People think this is related to the lymphatic system because it's a key structure to produce CSF for the fluid, the movement, and most of the studies on the choroid plexus, they only use the volume because they don't have the resolution and also the contrast. So on the 70 using the USPLO, the contrast, we can see the details. For on the top row, there's a young person. We can see kind of like the stroma tissue on the top, and also the vascular component on the bottom. And so we can. It looks like the virtual histology. You can see different part of the choroid plexus, and also in the old people, we can see the size is increased, and the increased one not only not the part of the vasculature. If you see the QSM, there's a lot of the increased size appears a higher signal. That's X classification, not the vascular. The vascular is supposed to appear dark. And yeah, this is another case for the MCI patients. We can see not only the size increased, but also the cyst formation inside of the choroid plexus. This is quite matched with the histopathology findings. The Sagar also found the increased detection of central vein sign in MS lesions using USPLO enhanced MRI. This is also quite interesting. And in terms of the safety of the ferromoxitol, I don't want to yeah, basically we found not only from our data, but from the original, the trial data is from the 2.1 million patients, and also the recent paper by Dr. the Kim Lian, the Nguyen, and also our own data. We found there's no single severe case was reported from 160 patients. And of course, the imaging dose is quite lower than the treatment dose. So in summary, so clinically, we think the micro may provide a novel way to assess the vascular density, small artery tortuosity, and also the choroid plexus changes. And more studies, of course, are needed, for patients with tumors, stroke, and AVM and AD. So finally, I would like to thank many people, especially the people from Wayne State, including Dr. Heiki, Sagar, and Yun Sheng for this study. And also thank you for your attention.
Thank you very much for that very interesting presentation. Given time, we'll be moving on to the next presentation. on non-contrast intracranial dynamic MRA using arterial spin labeling. Presenting will be Yuriko Suzuki from Oxford University.
Thank you very much for inviting me here today. It's such an honor and a very great pleasure to be here. So my talk is about a non-contrast enhanced intracranial dynamic MR angiography using arterial spin labeling techniques. So I'm usually around among people from the ISMRM's perfusion study group who use ASL for perfusion imaging such as CBF or other hemodynamic parameters. So mostly focusing on microvasculature. So among them, I am in a kind of underrepresented group using ASL for visualizing macrovasculature. So I am very happy to be here finally with angiography people. So, but I think ASL MRA is not very common yet. So in this talk, I would like to show you what ASL MRA can do and share some challenges and consideration for its clinical applications. So without doubt, time-of-flight MRA is a workhorse of the non-contrast MRA, providing completely non-invasive and providing high spatial resolution within a very reasonable scan time. So its contribution to everyday's clinical diagnosis is significant. However, even such a workhorse is not always successful. For example, this time of flight was acquired after a bypass surgery to confirm the bypass is functioning. However, in time of flight, the border of the multi-chunk acquisition, which is commonly used in time of flight to improve the visualization of distal arteries, hit the bypass artery, then the signal of the bypass flow was suppressed by the venous saturation slab. Then it looks like the bypass is not functioning. In contrast, ASL MRA doesn't use the venous saturation slab. So the bypass flow was successfully visualized like this. In this case is an intracranial hemorrhage that happened in a young patient. So considering the age of the patient, an AVM was suspected. However, the time of flight was not very successful, probably because this hematoma showing the hematoma is elevating the static tissue signal. However, ASL MRA is generated by subtracting the two images of the label and the control images, which subtract the static tissue signal. So ASL MRA was successful in visualizing the AVM nidus and its feeding artery. Here is another example of AVM in which the labeled blood flowing through feeding artery and nidus and even draining veins are clearly visualized, not only showing the location and the size of the time of the nidus, which can be achieved by time of flight, but ASL MRA can suggest the pattern of the draining venous flow. For example, in this case, this blue arrow is indicating an anterograde flow into the sagittal sinus, but this pink arrow might be a retrograde flow into the cortical vein, which is significantly related to a high incidence of brain hemorrhage, and such information is crucial in to determine the urgency and treatment option. So this image was acquired after STA-MCA bypass surgery, and on the right-hand side, ASL MRA shows a close flow from the ACOM artery first, then which is followed by bypass flow from STA. But I think this is a little too complicated to distinguish blood flow from the ACOM artery or bypass flow. In such a case, vessel selective labeling would be very useful. So Another very important advantage of ASL MRA is the ability to perform the spatial selective labeling. For example, these two images were acquired using the vessel selective labeling, exclusively targeting the ICA and ECA separately. So if we apply this vessel selective labeling to the case in the previous slide, we could be able to distinguish the blood flow from the ACOM arteries or SDA bypass more clearly. So I hope so far I'm successful at convincing you that ASL MRA is clinically useful, but I think you may have a question, is ASL MRA widely used in clinical examination? And I would say, unfortunately, the position of ASL MRA is not, well, still stays as a clinical research. And I would like to discuss why. So this is my favorite vessel selective ASL MRA, published in 2015, 10 years ago. So very big AVM nidus was visualized by time of flight very clearly. And additionally, vessel selective ASL visualizes its contribution to the AVM nidus from right ICA, left ICA, and the vertebral arteries. After 10 years, why isn't everyone using this technique yet? So this is a very crucial challenge, is that so we are very successful in developing novel labeling schemes, but actually we are not very successful in implementing the robust and user-friendly planning method to the MRI scanner for the everyday clinical scans. So vessel selective ASL requires a very careful planning of the labeling plane perpendicular to the target arteries, while avoiding any other contamination or mislabeling from the different non-target arteries, then working on multiple labeling and multiple survey or localizer images. So radiographers cannot do this in a very busy examination slot. So this optimized encoding scheme is trying to tackle this problem. So the operators define the target artery. I'm sorry, I'm not very successful with it. So operators define the target artery, location of the target arteries, showing that black dot, then also non-target arteries shown in white dot. Then this spatial arrangement at the labeling plane is Fourier transformed into the frequency domain. Then the maximum intensity point with a lowest frequency, spatial frequency, determine the optimized vessel selective parameters. So Fourier transform this back to the spatial domain demonstrates optimized vessel selectivity. For example, these target arteries are both in a labeled plane, labeled condition, and these two white non-target arteries are in control conditions. So this method was recently updated, then applied to ASL angiography above the circle of Willis with even more complex geometry. But it showed successful the robustness and successfully showing the vessel selective angiography like this. So this approach is still under research, so requiring the input from the operators. But hopefully the current progress of the AI-based methods will help for us to implement more user-friendly or robust, or maybe even more completely automated planning method to MRI scanner so that radiographers do not need to worry about the planning. The other things that came to my mind was the target clinical application. And these two images are very good example. The image on the left-hand side was acquired from a young healthy subject, and very small distal arteries are clearly visualized. In contrast, the image on the right-hand side was acquired from an elderly subject, and the visualization of distal arteries is not as good as one on the left-hand side. So this is because of the slow blood flow, which is very common in elderly patients. So ASL uses two images, the labeled and control images. Then in labeled image, the labeling inverts the blood magnetization, which recovers with time like that red lines. Then the control image is acquired without the labeling. So the blood magnetization is ideally unperturbed. However, we have to consider take into account the imaging volume. So each time excitation pulse is applied, the recovery of the labeled blood magnetization is accelerated, and the unperturbed blood magnetization in the control image gets saturated. Then taking both effects together, it's clear that ASL signal decreases significantly. So how can we reduce this RF exposure? One option is the splitting 3D imaging volume into 2D slices, like we used to do in time of flight for large field of view. As I mentioned earlier, ASL does not use venous saturation slab. So we don't need to worry about accidental arterial blood suppression. However, time of 2D slices are much thicker than the typical slice thickness in the 3D acquisition. But maybe we can use super resolution or something. So here are example images of the conventional 3D acquisition and 2D acquisition with super resolution. As expected, the 2D acquisition can visualize more distal arteries in later dynamic phases. So, and actually it's quite clearly with the help of super resolution. So today I couldn't cover any other ASL's state of arts like labeling schemes or undersampling or low rank approach or those kind of things. But today I really wanted to focus on how to make ASL MRA more useful in clinical use, even including steno-occlusive disease. And I think this is the very important direction we should consider to go. So yeah, this is the last my last slide, and I hope it gave you some view of the ASL MR angiography. And thank you very much for your attention.
There is time for one question if anybody in the audience has one. If not, could I ask considerations of trade-offs between temporal and spatial resolution? Any thoughts on that?
Yes, ASL angiography is unlike the contrast-enhanced angiography. We don't need to acquire one single image in one go, like a real-time dynamic. So we can split like a segmented acquisition. So of course, if we want both of spatial and temporal resolution together, then scan time will be longer, but it's still kind of flexible. So that's, I think, also one of the very important advantage of ASL angiography. Thank you very much.
Thank you. Thank our speaker again. Then I'd like to introduce our next speaker, Elena Kui, who will be speaking on atherosclerotic disease and its association with future stroke events. Thank you.
Thank you, David, and thank you, organizers, for inviting me. It's a great pleasure to give a presentation for the SMRA community. So I have no conflicts of interest to disclose. So carotid atherosclerotic plaques are the underlying cause of approximately 20% of all ischemic strokes. And during decades, atherosclerotic plaques develop, and they can transition from a stable plaque to a vulnerable plaque. And in this vulnerable plaque, you can have intraplaque hemorrhage, a large lipid reticular core, a thin or ruptured fibrous cap. And when this cap ruptures, then the blood gets in touch with the thrombogenic material in the lipid core, which leads to acute thrombus formation, embolization, and can cause a stroke. And the risk of ischemic stroke highly depends on the composition of the plaque. So with carotid imaging, we can estimate the stroke risk and contribute to primary as well as secondary prevention. And it has been shown by many researchers that using multi-contrast MRI, that you can use visualize the main components of the plaque. So in the post-contrast images, the lipid-rich necrotic core does not enhance after contrast injection. And if you see no continuous signal of signal enhancement overlying the lipid core, this indicates that the fibrous cap is either thin or ruptured, because the fibrous tissue typically strongly enhances after contrast injection. And calcifications can also be recognized because they are dark on all the MRI contrast ratings. And intraplaque hemorrhage, which contains methemoglobin, which has a very short T1 relaxation time, appears bright on dark blood, heavily T1 weighted gradient echo images. Intraplaque hemorrhage is at the moment the most established imaging marker on MRI for stroke risk. And a few years ago, in a large individual patient-based meta-analysis, Andreas Schindler and collaborators showed that intraplaque hemorrhage is a very strong predictor for ipsilateral stroke. It is stronger than any of the known clinical risk factors, including the degree of stenosis. And this was not only the case in the symptomatic patients with significant carotid stenosis, but strikingly, you can see that also in symptomatic patients with less than 50% carotid stenosis, that the stroke risk, if they have intraplaque hemorrhage, is actually very similar to the symptomatic patients with intraplaque hemorrhage and significant stenosis. Because you see that those patients had a risk of almost 50% of experiencing an ischemic ipsilateral stroke within 4 years. And this is a very high risk. And considering that these patients are currently not eligible for carotid surgery to prevent a recurrent stroke. And it seems that some of these patients may actually benefit from carotid revascularization as well, because they are at such a high risk. In the Netherlands, we have performed a very large multimodality, multi-center trial to compare the predictive value for stroke, for MRI, MD-CTA, ultrasound, as well as transcranial Doppler. And we did this in a population of symptomatic patients with less than 70% carotid stenosis and a plaque of at least 2 millimeters in the ipsilateral carotid artery. Before we started our study, we defined 4 primary imaging parameters, which were intraplaque hemorrhage and total plaque volume on an MRI, and the presence of an ulceration and the proportion of calcifications on CTA. In the Paris study, we confirmed that intraplaque hemorrhage is a very strong predictive marker for ipsilateral TIA and stroke, as you can see in the Kaplan-Meier plot on the left. On the other hand, the presence of an ulceration on MD-CTA, although these patients with an ulceration had a lower stroke-free survival, this did not reach statistical significance. And this is also reflected in the Cox proportional hazard ratio. So both primary MRI parameters were significantly associated with ipsilateral stroke risk, while the MD-CTA parameters did not reach statistical significance. So MRI is actually superior in these patients to predict TIA and stroke risk. We also explored a large number of secondary imaging parameters and blood markers, but from all these secondary parameters, only maximum plaque area on MRI and total plaque volume on ultrasound were associated with the clinical endpoint, ipsilateral TIA or stroke during clinical follow-up, or the imaging-based endpoint, which was a new infarct on neuro-MRI. So there are many features of plaque fundability, and therefore recently Luca Saba and collaborators published a paper where they proposed a novel system for radiological reporting of carotid plaque composition. And this score represents the most severe plaque lesion. And you can use it for ultrasound, CT, as well as MRI. And there are 4 main categories. And these categories are based on the risk reported in literature for the various individual plaque components. So plaque RADS1 is a normal vessel wall, and the most severe category is plaque RADS4, which is a plaque with intraplaque hemorrhage, fibrous gap rupture, or intraluminal thrombus. And last year, Huang and collaborators have validated the use of plaque RADS in the clinical practice by attributing a plaque RADS score based on a combination of CTA and MR images, and they showed that plaque RADS significantly improves stroke risk stratification over traditional stenosis grading. However, in daily clinical practice, it is impractical to do an MRI as well as a CTA. So therefore, in Maastricht, in the Paris population, we also evaluated the plaque RADS score based on only CTA, only MRI, or a combination of both modalities. And although CTA was able to differentiate different risk categories for stroke risk, MRI did a much better job, and there was only a slight improvement if you combined the information from CTA and MRI. So again, MRI is superior in predicting stroke in patients with a carotid plaque. So a challenge is still that if you would use carotid imaging to select a patient for carotid surgery, carotid endarterectomy, then you can see that in patients with less than 70% stenosis, that the prevalence of intraplaque hemorrhage or a plaque RADS4 score is quite high. So for example, in the Paris population with patients with mainly mild carotid stenosis, the prevalence of intraplaque hemorrhage was already 37%. So if you would select all these patients for surgery, it may lead to an overuse of carotid revascularization. So therefore, we aim to develop a clinical prediction model to calculate the ischemic stroke risk in symptomatic patients with carotid stenosis. This is the IMPROVE model, which we published this year in Stroke. And the IMPROVE model predicts the individual stroke risk based on the most important clinical risk factors and the presence or absence of intraplaque hemorrhage on carotid MRI. The score was developed using a large data set of 760 patients with recent TIA stroke with a plaque of at least 2 millimeter and maximal 99% stenosis from 5 large cohort studies. And in this database, we had 65 recurrent ipsilateral ischemic strokes during a follow-up. And we compared the characteristic of these patients to the large data of the ECST trial, and we found that the demographic parameters were very similar. Only the patients in our database were slightly older, which is attributed to demographic changes in the last 2 decades. We tested the performance of the model by calculating the z-statistic, which was 0.82 after internal validation, which indicates an excellent performance of the model to predict ipsilateral ischemic stroke. And for example, in comparison, at the moment, the most used model is the ECST model, also known as CAR score, which had a z-statistic of only 0.67. And also the calibration of the IMPROVE model was good with a slope of 0.9. So we wondered whether we can use the IMPROVE model to select patients for carotid revascularization. So therefore, we performed a Monte Carlo simulation comparing 2 scenarios, a care as usual scenario, where all patients with 50% stenosis or higher were selected for carotid revascularization in the simulation, and with a lower degree of stenosis, they were selected for medication only. And in the improve scenario, we calculated the improve risk based on the presence of interplaque hemorrhage on MRI and the clinical risk factors. And patients with a high improved risk for a recurrent stroke were simulated to undergo carotid revascularization, and patients with a lower risk were simulated to undergo optimized medical treatment only, so medication only. And we performed 10,000 probabilistic Monte Carlo simulations. Here you see the results of the model-based study. We tested the combined endpoint, ischemic ipsilateral stroke and perioperative strokes and deaths. And we found that there was a reduction in the improve-based arm of 35% of this clinical endpoint. And in addition, also the number of revascularizations could be reduced by 90%. And also there was a cost reduction of more than 6,000 euro per patient. In a sub-analysis, we also tested the cost effectiveness of this model-based study in each stenosis category. So in patients with less than 50% stenosis, in the care as usual simulation, none of the patients underwent revascularization. And in the improve arm, 18% of the patients exceeded the risk threshold and were simulated to undergo revascularization. And now, because these patients at high risk underwent revascularization, there was a reduction in number of strokes because now preventive surgery for long-term stroke prevention was performed in these high-risk patients. In the categories of patients with 50% stenosis or higher, in the care as usual simulation, all patients underwent revascularization. In the improve arm, this could be reduced to 47% for patients with 50 to 69% stenosis and 84% for patients with 70% stenosis or higher, because now these patients were actually identified as being at low risk. And this also led to a reduction in strokes because now the low-risk patients did not need to undergo a revascularization, so there were less perioperative strokes. So in conclusion, carotid MRI is the most suited modality. Interplaque hemorrhage is very strong predictor for stroke. Carotid plaque RATs allow standardized reporting, and the improved risk score has a good discriminative value. And in a model-based study, we showed that it can lead to less clinical events. And in 2026, we started a large trial in the Netherlands to test this in an empirical study. I would like to thank you for your attention.
Lena, I want to thank you for that great presentation. Unfortunately, time doesn't permit questions, but I think this is very illustrative of the kind of study that's going to move our field forward and make it clinically relevant and really what we need. So again, I want to thank all the speakers, hand over the session out to the next set of moderators, Mahmoud Mosabasha and Roy Lee, and thank you all.
Hey everyone, thank you for joining us for this section on head and neck MRA scientific sessions. I'm Mahmoud Mosabasha from the University of Washington, and I'm going to be one of the moderators and my co-moderator.
Yeah, I'm Ray from Tsinghua University, and the first talk of this session is from Yulin Ge from NYU, and his talk, the title of the talk is Imaging and Clinical Impact of Cerebral Vascular Tutorials. Please.
Thank you, Ray, for the introduction. So yeah, the topic is the imaging in the vascular tortuosity. The most work was done by Jill Swing, who is the former PhD student in my lab, and I'm here just to present. And we know the aging is the single most significant risk factor for AD and related dementia. And recently, we know that the vascular changes plays a key role in to this risk. These vascular changes include the increasing the tortuosity in both large and small arteries. And so what drives the tortuosity? So we think it is the accumulative and the decades-long assault from both the mechanical and the inflammatory activities on the vascular wall. And think about the impact by this nonstop the cardiac positive the blood flow on the vascular wall, which eventually can wears down the elastic component in the vascular wall and also trigger the inflammatory the cascade that cause the elastin degradation and also the collagen build up and eventually cause the tortuosity. And we often use the TOF and the phase contrast MRI to evaluate the large brain fading arteries in the neck. And the TOF is very good for the morphology evaluation, and also we can use TOF to generate several tortuosity quantitative tortuosity measurements. And the phase contrast can be used for the quantification of the blood flow. So using a large, the adult lifespan data sets, previously we showed that with increase of the age, the internal carotid artery also becomes the more tortuous. And the starting point of this significant change actually around the age of 60. And we also see, this correlation, the positive correlation with between the tortuosity severity and the age. And also the blood flow measured on the PC is also decreased with age. And recently we showed that in the sub-cohort of this, the participants aged of the 65 and above, and with increase of the tortuosity, there's increase of the white matter hyperintensity in the periventricular region. So that's indicating there's some the link between the extracranial vascular morphology changes and the intracranial the lesions. And for the imaging, the small vessel tortuosity, we have been focusing on the medullary arteries. These arteries are crucial to supply the blood to the deep white matter, where the white matter hyperintensity often occurred. And so we see when we see this, the flare imaging, we know this is the white matter hyperintensity. Sometimes we also call this is small vessel disease. Actually, we don't really see the vessel changes, the abnormalities, even though on the histopathology we can clearly see there's a small artery tortuosity. So there's no current imaging to really detect this small artery the tortuosity changes. So as previously I talked, using the USPO enhanced SWI, we can really see the small vessel changes. And this example to show pre and post contrast the SWI, we can see the tortuous arteries, which are not seen on the pre-contrast. On the pre-contrast, only in the veins has been showing. And so this is, I think it's very exciting because not only we can see the small arteries in the young people, but we can see a lot of actually tortuous arteries in the old people. And this is quite, directly the mirrors with what has been reported in the histopathology findings. And also the tortuosity severity is also increasing with the age. These are some correlations, with the both numbers and tortuosity severity with age. And also we found the number of tortuous arteries increase with BMI, which is also vascular risk factors. And interestingly, we've also found the starting point of significant change for the small vessels starting a decade earlier than the large vessels as shown here. One is 50, one is 60. And the regions has the higher number of the tortuosity vessels also have a high number of vascular hyperintensities. And another interesting finding is in some, the perivascular space, dilated perivascular space, which can be shown on the T2 and T1 weighted imaging. And after giving the contrast, there is a small, the tortuous vessels can be seen. And this is also the first time to see these kind of things, because before we only can see the dilated the space. And this is also confirmed by the histopathology findings, showing the coiling the arteries in the dilated perivascular space, and the number of the tortuous vessels in the perivascular space correlated with age. And yeah, this is the last slide. So as I mentioned earlier, so when we're thinking about the cause of this the tortuous vessels, so there's two factors. So one is mechanical, one is the inflammatory the activities. So for the mechanical part, we think it's more like the river meandering effects. In this case, the river in the Amazon. Over the years, it can become this the tortuous the formation. And but in the river there's no inflammation the component. This is why in human vessels it can happen earlier and quicker. So so this brings our attention that really we need to really study these two factors, the mechanical and inflammatory on the vessel wall, because these vascular morphology changes can really slow down the blood flow and also cause a lot of the events such as hyperintensity, white matter hyperintensity, the blood-brain barrier disruption, and also microbleeds and the brain atrophy over time. I think that's my last slide. Thank you so much for your attention.
Yeah, this talk is open for question. So any question from our audience? No? Yeah, you go ahead.
I have a question. So, you very eloquently described tortuosity, and we've seen in a lot of the literature that tortuosity is associated with a lot of end-stage processes, including, as you mentioned, white matter hyperintensities, ischemic stroke, hemorrhage, aneurysm formation, dementia. I'm wondering, in your opinion, do you think that the etiologies that contribute to tortuosity also contribute to those end-stage processes, or do you think it's sequential, where it causes tortuosity and the tortuosity contributes to those end-stage processes?
Yeah, this is a good question. I think this is a kind of the understudied area still, because we found like in the area of with more the small tortuous vessels, there's also some the white matter hypertension. Also, we found there's when the people getting older and a lot of the neck vessel getting tortuous, they also develop some more the hyperintensity. Which comes first? We don't know. But our evidence showed small vessel like 10 years earlier can happen. So, but I think it's still a good question to really to see which one causes more tissue injury.
Okay. Due to the limited time, we move to next talk.
The next talk is by Ioannis Kogsoglu. Sorry if I'm not pronouncing your name right. Quantitative time of flight MRA improves morphologic agreement of the intracranial arteries with respect to dark blood intracranial vessel wall MR.
Thank you, Dr. Musabasha, for the introduction. It's a pleasure to be here and be able to share our work. So I think, as many of you are aware, conventional time of flight, head MRA, is a very useful test that's often applied clinically to either detect pathology, but also to monitor it over time. However, it's well known that the conventional time of flight MRA exhibits artifacts from blood flow that can distort arterial shape and affect precise structural evaluation of arterial cerebrovascular pathology. Also, as a side note, it's more of a structural exam, and it doesn't provide measurable hemodynamic information, which would be nice to obtain if we spend 5 to 8 minutes acquiring the exam, but also to potentially, quantify hemodynamic aberrations within the brain. So recently, a quantitative time of flight variant for head MRA that also provides hemodynamic data has been reported. So in addition to providing hemodynamic data essentially at no cost because there's no additional scan time, it does show the potential to reduce blood flow related artifacts that, as I mentioned before, are known to affect conventional head MRA. So the purpose of our study was to evaluate the morphologic agreement intracranial arterial lumen as portrayed by conventional time of flight head MRA, as well as quantitative time of flight head MRA. And we did this by comparing our results to dark blood MRA, specifically intracranial vessel wall MRI or VWI, as we've heard a lot about at this meeting. So this was an IRB-approved study, and we included 21 adult patients with a history of cerebrovascular disease, primarily included patients who had known intracranial stenosis or an intracranial aneurysm. We imaged at 3T using 3 imaging sequences, conventional time of flight MRA, quantitative time of flight MRA, and at T1 space, kind of dark blood MRA or vessel wall imaging exam, and all these scans were required without contrast. We registered the MRA data sets to the T1 space vessel wall imaging volumes. We segmented the intracranial arteries, we skeletonized them to obtain vessel center lines, and we created reformations orthogonal to these vessel center lines every 1 millimeter. These reformations were interpolated, and we used an objective and automated full width at half maximum based signal analyses to define arterial cross sections on each one of these reformations. And we did exclude some cross sections where we couldn't reliably identify arterial boundaries. So for the locations that were included in the final analysis, roughly about 12,800 over these 21 cases, we computed 2 metrics, the first of which is luminal cross-sectional area, and this was computed for all 3 protocols. We compared this metric using interclass correlation coefficient for absolute agreement. We also looked at Pearson's correlation. And the second metric was dissimilarity coefficient of luminal boundaries were calculated for both the conventional time flight head MRA as well as the quantitative time head MRA with respect to the dark blood vessel wall imaging exam. So this slide is basically a tutorial summary of our methodology where we constructed these reformations. We did lumen segmentation using kind of an objective way, and we looked at these 2 metrics of lumen area and dissimilarity coefficient. So moving on to the results, when we looked at the lumen area analyses, we found that both conventional time of flight head MRA, shown on the plot on the left, and the quantitative time of flight head MRA showed very strong absolute agreement in terms of ICC values, as well as Pearson's correlation or R values. However, slightly higher values were obtained with the quantitative time of flight technique, as you can appreciate at these highlighted numbers here. When we move to looking at dissimilarity coefficient, and this is a metric that looks at positional as well as morphologic agreement between the 2 exams, we found that compared to conventional time of flight head MRA, we found that the quantitative time of flight MRA technique provided significantly larger DSC values, indicating improved positional and morphological correspondence with respect to vessel wall imaging for defining and depicting the arterial lumen. If we take a look at one kind of DSC value map, so these are kind of close-ups of the circle of Willis in one case, we can see that the quantitative time flight technique provided slightly larger values in a number of locations within the circle of Willis, and so more yellowish and whitish regions denote higher values. And this was a consistent finding across our study, across the 21 cases. When we looked at locations of pathology, again, we found significantly higher, better dissimilarity coefficient values with the quantitative technique at arterial stenoses and in aneurysmal locations. And both of these findings were statistically significant. So kind of wrapping up, so compared to conventional time flight head MRA, we found that the quantitative time flight head MRA significantly improved morphologic agreement with respect to dark blood MRA or vessel wall imaging for displaying the intracranial arterial lumen. And we believe these findings may have implications for either the detection or for the quantitative evaluation of various cerebrovascular pathologies. And we hope to kind of pursue this line of inquiry in the near future and perhaps apply this approach not only in the head, but see if it might work in other vascular territories. Thank you.
Thank you so much for the talk. Any questions?
Yeah, very nice results. You use the vessel wall imaging as a reference standard, but it may also have flow artifacts because you don't use MSD or Dante. Have you considered using like contrast enhanced MRA or CTA or DSA as a reference?
Yeah, first of all, we didn't observe much flow artifact in our scan, so I think that needs to be clarified. We didn't inject any sort of gadolinium, which makes these artifacts more prevalent. We are looking at possibly correlating our results, like especially in arterial stenoses or aneurysms with DSA, but that wasn't the focus of this study, but definitely could be done. The initial impression from my clinical collaborators is just their feeling is that this quantitative time of flight technique, the vessels are more clearly displayed or things just look more real to them. But we didn't really have proof, and this was kind of our initial foray at trying to see if we get better correspondence to a more anatomic exam, which was what we used the dark lead MRA exam for. But definitely, absolutely, we should compare that in the future, and we hope to do so. Thanks for the question.
Thank you.
One quick question I wanted to ask. I was wondering, and I know this might take longer than we have, but you mentioned that the quantitative MRA can overcome flow dephasing and show flow in areas where it may not show on the time of flight MRA. I was wondering if you could maybe briefly explain that.
Oh, right. So I want to clarify that it's not necessarily dephasing, it's just distortion of the vessel lumen. We believe it's because we're using a stack of stars-based acquisition, so there is no phase encode gradient and a separate, well, there is a readout encode gradient, but there is no phase encode gradient. And these shifts are known to occur because of the time gap between the phase encode gradient and the frequency encode gradient, which we eliminate with this sequence, at least in plane. So, but yeah, I think more work needs to be done to look at whether we can reduce signal dephasing artifact. But we haven't looked at that, but hopefully we can compare it with DSA in the future and kind of get at that somewhat.
Thank you so
Thanks
much
for the question.
Okay, our next speaker is Zhecheng Meng. He here? Yeah. So he's from Peking University Third Hospital. The title of his talk is about the correlation between characteristics of carotid vulnerable plaque and lacunar infarction.
Hello, everyone. It's a great honor for me to attend this annual meeting and present my research topic. I come from Peking University Third Hospital. The topic of my presentation is investigating the association between carotid atherosclerotic plaque characteristics and lacunar infection using high-resolution vessel wall imaging. I will present the report in the following 5 parts. Cerebral small vessel disease is a clinical syndrome caused by sculptural or no impairment of small cerebral arterioles, capillaries, and venules, which can lead to various cerebral vascular events. It includes a variety of imaging findings, such as lacunar infection, vitamin high signal, cerebral microhemorrhage, and enlarged perivascular space. A community-based cohort study in China found that the incidence of lacunar function in the trans population was higher than the average level in the world. Previous studies have found that carotid atherostenosis is independently associated with the occurrence of lacunar infection. However, there are still insufficient studies on the characteristics of vulnerable plaques, such as intraplaque hemorrhage and carotid lipid-rich necrotic core, like this. So this study aims to explore the association between the characteristics of carotid arterial plaque components and lacunar infection, and conduct a subgroup analysis based on the severity of lacunar infection. We recruited a total of 194 patients with moderate to severe stenosis of the carotid artery. Collect the clinical data of the patients. The inclusion criteria are as follows. All patients underwent carotid vessel wall imaging and brain MR imaging. The scanned sequence and parameters are as follows. Assess the morphological and compositional characteristics of the plaques and the situation of lacunar infection in the patients. The patients were further divided into different subgroups based on the number of the lacunar infection. As shown in this picture, it presents the characteristics of carotid arterial plaques and the imaging factors of lacunar infection lesions. The application of high-resolution imaging of the carotid artery can enable the qualitative and quantitative assessment of the characteristics of atherosclerotic plaque components. The statistical methods are as follows. About our research results show that the patients with lacunar infection have the higher blood lipid levels. It should be noted that in this study, there was no correlation between the morphological characteristics of the vessel walls and the lacunar infection. So this part wasn't included in the research results. We can see the patients with lacunar infection have a higher level of calcification burden in their carotid plaques. And this remains the case even after adjusting for confounding factors. The difference is that in the subgroup discussion, it was found that patients with severe lacunar infection had increased the plaque vulnerability. The volumes of intraplaque hemorrhage and carotid lipid-rich necrotic core were larger. The carotid arterial plaques of lacunar infection patients have a higher level of calcification burden, and plaque calcification represents an integral component of plaque progression, marking the chronic evolution of atherosclerotic disease. So in summary, our study demonstrates that the carotid atherosclerotic lesions may act as an effective indicator for lacunar infection, especially the vulnerable plaques, including intraplaque hemorrhage and carotid lipid-rich necrotic core, may be effective imaging indicators for severe lacunar infection. This study has several limitations. Firstly, in terms of the sample size, the number of patients with severe lacunar infection is relatively small, which results in a lower number of individuals with plaque ulcers. Furthermore, we didn't conduct further investigation into the relationship between plaque characteristics and other imaging signs of CSVD. So in the future, we will further include the proportion of patients with severe lacunar infection and fully assess the association between the plaque characteristics and vital matter high signal, cerebral microhemorrhage, and so on. Thank the institution for its support for this research. That's all. Thank you.
So any question from audience?
Sure, I had a quick question. So I don't know if you mentioned it, but did you rule out intracranial disease? Did you do intracranial vessel wall imaging?
I'm sorry, can you pardon your,
Did you perform intracranial vessel wall imaging in these patients?
Yeah, actually, you do the large coverage from external cardiac artery to internal
yes.
So Mahmoud's question is about whether you analyze the internal part of the vessel imaging. You only show the cardiac results.
About my
But I have another question about this. You have told us you find the intraplaque hemorrhage and also the lipogenic is more prevalent in the severe LAC patients.
yes.
How to define the severe?
The stenosis is greater than 70% in their carotid artery.
That is a severe stenosis, not the severe LAC.
It's severe LAC. The number is larger than 10 lesions, the kidney infection.
Okay, got it. Thank you.
Thank you.
All right, so the next speaker is me.
It's you. Yeah.
So I'm presenting for my fellow, Cristina Sanchez-Vizcaíno, who couldn't come. And I'll be talking about the utility of vessel wall imaging in clinical practice at a stroke center. Disclosure. So as we know, conventional vascular imaging misses the boat a lot of times, and vessel wall imaging can provide more characterization in terms of vascular disease and potentially diagnosis, as we've seen in this meeting. And our goal was to really evaluate how comprehensively incorporating vessel wall imaging into our stroke MR protocols could impact diagnosis, both in terms of changes in the etiology after MR with vessel wall imaging, and also characterizing imaging features in those patients that stay in the ESIS category at the time of discharge. This is a retrospective study of our database, and we looked at patients who went through that stroke protocol in the window from June 2022 to November 2023, and patients with limited image quality or incomplete clinical data were excluded. We established the diagnoses at the time before MRI, after MRI, and then at the time of discharge. And we had 3 radiologists who reviewed all the vascular imaging and MR imaging that we underwent. And these etiologic diagnoses were established by a stroke neurologist at these 3 time points. So starting off, we had 651 cases. When we whittled down, we had a total of 307 stroke patients that we included in our analysis for this study. In terms of looking at those 307 cases, at the time immediately before MR, 176 of those cases still didn't have an etiologic diagnosis for stroke. And from those 176, 46 of those were reclassified after the MR with vessel wall imaging. And based on that vessel wall imaging, almost half of those cases were reclassified based on the imaging into large artery atherosclerosis, into cardioembolic etiology, secondary to other etiologies being ruled out, as well as 4 cases of dissection that were detected on vessel wall imaging and 2 cases of moya-moya. In terms of looking at the ESIS cohort, those patients that when discharged still carried the diagnosis of ESIS, there were 45 of those, or 15% of the cohort. And amongst those, 20% of them had multi-territorial infarcts. And in addition, 24% had strokes while on platelets, and more than half of those patients actually had recurrent strokes. These are ones that maybe if at baseline stroke event, if we would have better classified them and maybe potentially targeted treatment better, we could have prevented that second stroke. In terms of looking at our cohort, 40% of these patients in the ESIS category at the time of discharge had plaque rads greater than or equal to 3. And 10% of those had intraplaque hemorrhage. And in addition, 33% were ipsilateral, while 35% were on the contralateral side. In addition, a small cohort component of it had greater than 30% stenosis at the artery of target. And in addition, 18% of the cohort had AFib, and of those, more than half had a plaque rads greater than or equal to 3 in terms of an atherosclerotic disease. So in terms of vessel wall imaging, it can enhance our stroke classification and our ability to visualize lesions that may be contributing to stroke, especially in the setting of specific vascular diseases as well as in ESIS category patients. In terms of etiologies, multiple patients will have multiple mechanisms, including AFib, a pattern of embolic stroke, as well as high-risk plaques ipsilateral to the stroke event. And combining vessel wall imaging with MRI patterns can help reclassify ESIS beyond the TOAST criteria that we use. Thank you so much. And here is Christina that wasn't able to make it here.
Okay, this talk is open for questions. Any question from audience? So, Mamu, I have one question, very quick question about your study. We can see a vessel imaging have a great potential in clinical. I don't know the situation in US, but in China, actually, most advanced medical center using vessel imaging to find out the reason of the events, and I don't know whether what's the percentage of in America. It's only use top level hospital or can use in basic primary.
Yeah, so we did a survey back in we collected data in 2019 of a survey of the ASNR to evaluate how many institutions were doing intracranial and extracranial vessel wall imaging and how often they were doing it. And intracranially, about 55% of respondents were doing it back in 2019. In the carotids, around 25% were performing carotid vessel wall imaging. And for intracranial, it was for the reasons you would think. The main application was for differentiation of vasculopathies, followed by atherosclerosis, culprit plaque determination, ESIS diagnosis, and then aneurysm characterization was on that tail end. While for extracranial carotid disease, the interesting thing was the most common application was for vasculitis, or determination of vasculitis. In terms of comprehensive utilization in stroke, I think we're the only place that's really doing that. I don't think too many places are doing that. Usually most places are kind of applying it in the setting of a patient presents, neurology, does an MRA or CTA at some point, patient has a stroke or doesn't, but there's some sort of vascular disease that they detect. If they know what it is, they run with it. They say this is atherosclerosis because the patient has 5 risk factors and they have focal stenosis, so we're not going to do anything. We're just going to start treating them. But then for equivocal cases where they say it could be one of 2 or 3 things, then they perform vessel wall. That's usually the way it goes for us.
Okay, thank you. So let's move to the next speaker. I think next speaker is have the movie, and she's from Kennedy Kriegel Institute, Johns Hopkins, who is Dan Zhu. Is
Hello, the topic is dynamic velocity selective MRA. This work was initiated at the Johns Hopkins University and the Kennedy Krieger Institute. We moved to the University of Washington, Seattle, and continued this work as a new institution. I have no financial interest to declare. The velocity-selective MRA can preserve the angiographic signal and suppress the tissue background within a single scan. VS arteriograms were achieved by adding a spatially selective inversion pulse with a proper delay for venous noning and arterial inflow. The timing of the inflow is sensitive to the arterial flow rate. A shorter inflow time may result in missing distal signal, while a longer inflow time could introduce venous contamination. In this work, we instead proposed a dynamic VSMRA technique that obtains angiograms at multiple inflow times. The proposed technique exploits temporal sparsity of multiple inflow times. Using the golden angle rotated spirochated sparse parallel imaging GASP technique to achieve high spatial temporal resolution. Here, we implemented cerebral and peripheral applications of rapid large FOV dynamic VSMA at 3 Tesla. The cycle of dynamic VSMRA sequence starts with a 1 second pre-delay for signal recovery, followed by an adiabatic slab selective inversion pulse with an inversion delay for arterial inflow. After that, a Fourier transform-based velocity-selective saturation pulse train was applied before image acquisition to suppress static tissue signal below the cutoff velocity. Then a non-selective saturation preparation with an identical acquisition is obtained and subtracted to mitigate B0 and T1-induced artifacts for large FOV scans. Images were acquired with 3D stacked spiral turbo flash in chronoview. Multiple equally spaced TIs were sampled separately in consecutive cycles, with only one spiral arm for each TI rotated by the golden angle. The undersampled dynamic VSMRA data were reconstructed with GASP, which is regularized by the total variation sparsity transform along the dimension of TIs. IRB-approved scans were conducted on 4 healthy subjects at 3T Phillips on both the cerebral and peripheral stations. The brain dynamic VSMRA has 16 or 21 TIs range from 0 milliseconds to 2000 milliseconds, while the peripheral scans has 16 TIs range from 0 to 3000 milliseconds. This figure compares the cerebral dynamic VSMRA with time of flight and the single TI VSMRA. Compared to time of flight and TI of around 900 milliseconds images, TI of around 1500 millisecond images resulted in more distal and slow flow arteries, like vertebral and basal arteries, but were subject to recovered venous signal. The venous signal could be removed for dynamic VSMRA with multiple artery and vein contrasts. The mask of veins was calculated with both a short TI image with nulled venous signal and a long TI image with recovered venous signal. These figures demonstrate a representative 16 TI cerebral dynamic VSMRA from another subject with veins removed. Great vessel contrast and clear small branches are observed on images at long inflow times. The dynamic VSMRA nicely tracks the arterial inflow. These figures demonstrate a representative 21 TI cerebral dynamic VSMRA from another subject with veins removed. The dynamic VSMRA nicely tracks the arterial inflow at a higher rate at the cost of some extra scan time. These figures are representative images of the 16 TI peripheral dynamic VSMRA, clearly showing the inflow of the iliac and femoral arteries. In this work, we demonstrated the feasibility of the proposed dynamic VSMRA using GASP for image acceleration in obtaining fast, large FOV, high resolution, and high quality dynamic VSMRA images for both the cerebral and peripheral areas. The time resolved arterial inflow, and venous separation are excellently depicted in healthy subjects. Thank you for your attention.
Since the speaker is not here, so there's no QA. So we will move to, sorry about that. We move to the power pitch session. The power pitch session, we have 7 talks. Each talk have 3 minutes. The first talk is by Mahmoud again, and the title of his talk is a comparison of Dante blood suppression and conventional T1 weighted post-contrast space intracranial vessel MRA in moya vascularly patients. Yeah, that's it. Please.
Thank you, Ray. So I'm presenting for my fellow Dan. Disclosures. And so what we wanted to do is we've published a couple papers looking at how Dante pre-pulse incorporated with space can improve blood suppression image quality relative to conventional space in the post-contrast setting. But we did want to dig in a little more in terms of looking at specific disease states like moya, which is a steno-occlusive process and potentially has risk for artifactual enhancement. So we started off with 61 patients with moya vasculopathy with vessel wall imaging. And as we whittled it down, we ended up with 30 subjects with Dante and space, both acquired in the same scanning session, with 47 affected ICA or MCA segments. So we looked at another number of qualitative and quantitative metrics in terms of evaluating image quality, SNR and CNR. So in terms of that evaluation, we found that blood suppression in using Dante was significantly better than it was with the conventional space. In addition, quantitative SNR and CNR were equivalent between the 2 acquisitions. And we also looked at some enhancement features downstream from the occlusion, as well as at the point of the occlusion. What we found was that there was significantly less enhancement in the Dante acquisition than the conventional acquisition. You can see in this example, first of all, at the point of disease, there's a lot more enhancement on the conventional acquisition than there was on the Dante. And downstream, you can see there's kind of a halo of enhancement in the conventional, which all disappears on Dante, indicating that it is actually flow artifact. So Dante post-contrast can reduce arterial and venous blood flow artifacts and may reflect true wall enhancement and the degree of enhancement in these cases relative to conventional space. And it has the potential to improve image quality and improve vessel wall imaging diagnostic assessment in moya vasculopathies. Thank you so much. And here is Dan right here.
The second power pitch is from Shanghai Hospital, Bin Tian.
Okay, thank you for the introduction. And we know in recent years, the suburban coil has been used in clinical to reduce the rate of retreatment or additional surgery for intracranial aneurysm. Although the high-resolution vessel imaging has been used to evaluate embolization of aneurysm after treatment. However, the aneurysm embolization process has been not well being monitored after treatment with the bare or suburban coil. So in this study, we aim to monitor the dynamic change of aneurysm embolization after treatment with bare or suburban coil using high-resolution vessel image. We conducted a newly bare suburban coil coated with the PLGA, and the aneurysm was sutured by the venous punch to the side wall of the bilateral cervical carotid. Then the high-resolution vessel imaging DSA and histology were performed 1490, 270, and 540 days after treatment. Then the dog was scanned on the MRI for the T2 pre and post-contrast T1 image. And let's look at the result. On high-resolution vector image of 14 days, we can see the signal in the lumen outside the outer wall of the aneurysm mixed on both on T2 and preconstruct T1. After the contrast, we can see the aneurysm wall was significantly enhanced on post-contrast T1, but there was no apparent enhancement of aneurysm neck on 14 days. During the follow-up, especially on the 440 days, you can see the signal became uniform on T2 and T1 image, and the aneurysm wall was not enhanced, but the neck can be seen enhanced during the follow-up. For the pathology, the aneurysm neck was covered entirely by the new intima with different thickness, and the lumen was filled with collagenous connective tissue. So in conclusion, in this experimental study, we created the aneurysm model and placed the bare suburban coil. And the aneurysm neck lumen surrounding changes on high-resolution vector image can reflect the endothelialization, thrombus, and the inflammation process of the aneurysm after coil, making high-resolution vector image an effective tool for monitor the embolization duration of the aneurysm after the bare suburban coil. And in the future, this study should be conducted to the clinical patient to prove the initial finding. Thank you.
Thank you. The next presentation is from Yan Li from Tsinghua, who's going to be speaking on baseline wall permeability derived from DCE MRI correlates with growth of non-saccular intracranial aneurysms.
Thank you. I'm Sun Haozhong from Tsinghua University. I'm presenting on behalf of Yan Li. In clinical aneurysm, structural IA was a very common cardiovascular disease affecting nearly 3.2% of the population. Growing IAs are much more dangerous than stable ones. Recent investigation proposed the wall permeability as a predictor for the restructure risk of aneurysm. As we know, there is a substantial difference between Sakura IA and non-Sakura IA. So in this study, we aim to predict non-Sakura IA growth by baseline wall permeability from DCE MRI. 34 patients with unruptured non-Sakura IA were enrolled in this study according to the inclusion and exclusion rule. All the patients enrolled underwent at least 3 months of radiologic follow-up. We define the eye growth as at least 0.0 millimeters increase in eye size. The key trend was derived from the extended Catty-Toft model based on DCE MRI. To assess the degree of enhancement, we introduced the Wall Enhancement Index, WI. All the clinical and imaging characteristics were compared between the group of growth and the non-growth group using independent sample t-test. We found there are significant difference between the two groups of eye size, faces score, WI, and key trends. Whereas no significant difference in other clinical or imaging factors. This figure shows the ROC curve for predicting the growth of non-Sakura eyes. We can say that the key trends, showing the red line, demonstrate the best predictive performance of the growth of non-Sakura aneurysm. This figure shows a representative case. We can see the growth direction of the non-Sakura aneurysm is corresponded to the very higher key trends at the baseline. In this study, we found a significant difference in baseline key trends between growth and non-growth group, which indicates baseline key trend might be a risk indicator for non-Sakura eye growth. What's more, we observed that the very high key trends at baseline corresponded to the growth direction of aneurysm, which implies high baseline key trend might serve a biomarker for higher risk growth regions. That's all. Thank you for your attention.
The next speaker is from Nanjing Medical University, China, Dan Zhou. The title of her talk is about multi-parametric MRI biomarkers for early diagnosis and cognitive impairment in cerebral small vessel disease. Please.
Thanks for introduction. I will show you our recently work is multi-parametric MRI biomarkers for early cognitive impairment in CSVD. Cerebral small vessel disease, CSVD, is leading cause of vascular cognitive impairment in elderly. Pathogenesis involves vascular injury, lymphatic dysfunction, and neural inflammation. Conventional imaging markers may miss early cognitive decline, and integrating multi-parametric MRI biomarkers could improve the early in diagnosis. In 2012, the existence of lymphatic-like structures within the central nervous system was first confirmed in mice, and this system was termed the lymphatic system. And in 2013, intrathecal injection of glutamine tracer, and 2017, non-invasive approach was the first process to assess human lymphatic system function, MRA, LPS. And this study aims to explore the value of 3 MRI-based biomarkers, invest diagnostic universe of combined DTI LPS index, enlarged perivascular space, and the colloid planes volume. The investigate biomarkers emerge across CSVD cognitive stages and correcting image metrics with marker assess scores. And this is a retrospective cross-section study, and the group according to strive true criteria. Were standardized multimodal brain MRI 3T scanner and a deep learning model and the DTI LPS index calculated. On key results, biomarkers, turns, and corrections, DTI LPS index declined progressive, and the base ganglia EPVS numbers and the CPV increased with cognitive impairment. No significant difference for CSO EPS, volume to midbrain EPVS. And the MOCAC scores positively incorrected with DTI LPS index, inversely corrected with big D, Bechd's EPVS number and CPV. DTI LPS index inversely corrected with BG EPVS numbers. And the BG EPVS numbers distinguish the CSVD with nonsense as shown this. And the combined model detected the earlier impairment, AUC is surest, and the CPV is the best single markers for West and Forest. And the summaries findings support a vascular injury, lymphatic dysfunction, and neural inflammation pathway, and the multi-parametric MRI captures complementary aspect of CSVD pathology, and integrates in biomarkers and so early detection and subtype differentiation, portrait to guide personalized interventions. And the multi-parametric MRI biomarkers, DTI, LPS, EPVS, CPV, offer sensitive tools to early CSVD cognitive impairment detection and combine more the private status to diagnose actions. And the limitation is show this. Thank you for attention.
Thank you for that presentation. Next is Zhengzi Zhu from Mayo Jacksonville, who's going to be talking about Dante module optimization for 7T vessel wall imaging space with 0.5 millimeter isotropic resolution.
Thank you for the introduction. So as you have already known that at 7T, the T1 space with Dante preparation is very challenging because of the SAR restrictions. So the purpose of this study is we are trying to address this problem with simulation. So our method is, in addition to the standard Dante simulation, we also add the constraints of the SAR, as well as the M0 for the desired spatial resolution. And then we are trying to solve this problem to minimize the blood signal after Dante preparation and with all these constraints. And then after that, we use the optimized Dante parameters on the healthy volunteers with and without Dante. So this is a detail of the scan. And this is the Dante parameters that we found for this resolution. And this is the signal intensity comparison. And you can see that for the ICA and the superior sagittal sinus, the lumen signal was greatly reduced by about 70%. And this is one example from the 0.5 isotropic resolution T1 space with Dante on and off. So you can see the blood suppression effects on the superior sagittal sinus and also the internal cerebral veins. And then based on that method, we further increase the resolution to 0.38 isotropic resolution. And again, you can see the blood suppression effects on the superior sagittal sinus. But because of we increase the resolution, the SNR drops, so we have to use the DR recount to bring the SNR back. And this is another example at the ICA. You can see the blood suppression effects. So in conclusion, high resolution T1 space with Dante is possible at 7T, but you have to take care of the SAR restrictions as well as the M0 and also the SNR drop. But you can use the DR recount to bring the signal back, and maybe you can also use the PTX space to bring the signal back at the cerebellum. Thanks.
Okay, thank you for the talk. And the next one is from local university. The name of the speaker is Franz Immer Suha. I don't know how to pronounce this, so please.
Yeah, thank you so much. So I just would like to summarize our study. So the purpose of our study was to compare the accuracy of T2 prep, bright and black blood phase sensitive MRA and the Dixon-based boost MRA with carotid CT in assessing the degree of the stenosis. So NAST-based stenosis measurements were performed on both internal carotid arteries in 15 patients in a 1.5 Tesla MR scanner. So this we compared to the CT angiography results. Just our protocols. So the main difference was the larger FOV with the T2 prep boost MRA technique, and we use ECG gating there. But with the axial Dixon-based boost, we use the smaller field of view and without ECG gating. So these are our results. So both the coronal and the axial Dixon-based boost MRI had a really good correlation, showed a strong correlation compared to CT angiography results, and the blunt Altman analysis shows us that the T2 prep boost MRA technique is slightly overestimated the stenosis by 2.5%, and the Dixon-based MRI technique just slightly underestimated the degree of the stenosis. Indifference was 0.4%. So here you can see just a good correlation compared to the CT angiography. So you can see there are subtotal stenosis, and you can appreciate that we have a really good, nice MR angiography images with almost the same image quality. So to sum up, both excellent coronal boost MRI sequences accurately determine the degree of the stenosis and show good correlation with the CTA results. We also compare that there's no significant difference between the two types of MRA significance, and in this small patient population, there's a clinical significance of the slight over and underestimation is negligible. Thank you so much.
Thank you for that presentation. Our last, but certainly not least presentation of the session is from Yi-Yan Sito, who's going to be talking about high-resolution vessel wall imaging.
Thank you. My talk is to illustrate the utility of vessel wall imaging, the evaluation of intracranial arterial disease, which is typically investigated firstly by CTA and MRA in the first instance, which shows luminal imaging, occasionally supplemented by DSA for the flow dynamics. So vessel wall imaging, as you've heard from previous speakers, has a complementary role. We present a pictorial review from our experience with vessel wall imaging, covering the different diagnoses presented here. This is a rather complicated table summarizing the pathophysiology in each of these entities and what it looks like on vessel wall imaging, whether there's eccentric or concentric wall thickening, plus or minus enhancement. This is a patient with known atherosclerosis. There was an MRA done 10 years ago, which shows bilateral MCA-M1 disease with a pre- and post-synovial dilation on the right side. He came back again, and both the MRA and CTA shows similar findings with, again, rather similar appearances of the vessels, but it has progressed. Vessel wall imaging was performed. On the right MCA, at both segments of stenosis, we can see eccentric wall thickening with subtle enhancement from a ruptured fibrous cap. On the left side, there was intrinsic hyperintensity related to the lipid core or intrapleural hematoma, which therefore makes it clinically difficult for us to evaluate whether there's enhancement or not. The next case is one with a diagnosis of dissection. This patient presented to us, and there was complete occlusion on the right M1 MCA at the M1 origin, and on the left side, there was stenosis as well. The differential diagnosis was, is it atherosclerosis or is it dissection? We went on to do a DSA because of the question of dissection. The right M1 MCA shows complete occlusion, and on the left, we can see there was a filling defect, flap-like, indicating a likely dissection. Vessel wall imaging was performed. On the right side, you can see irregular wall thickening with eccentric enhancement along the involved segment. So there's underlying atherosclerosis. And on the left is a case of dissection complicating an underlying atherosclerosis with irregular wall thickening and enhancing intimal flap. This patient has a diagnosis of vasculitis. The initial MRA showed left ICA supraclinoid stenosis. CTA shows similar findings. We went on to do vessel wall imaging, where we can see concentric thickening due to inflammation with strong, smooth enhancement of the involved segment. So clearly, this is very, very helpful for this particular patient, and it's a diagnosis of vasculitis. Moyamoya disease is a bit more complicated depending on which paper, which author you read. This is an example of a patient with classical findings of Moyamoya disease on both CTA and MRA with tapered occlusion of bilateral terminal ICAs extending to the bilateral MCA and ACA origins. The question to us was, is it Moyamoya disease or Moyamoya syndrome? In classical Moyamoya disease, there is a vanishing MCA, there's a tapering and occlusion of the terminal ICAs with concentric wall thickening. It's either no enhancement or variable enhancement, depending on which author you read. In this particular case here, there was no enhancement of the wall. So we think this is more likely to be Moyamoya disease. This patient presented to us with a very interesting history. No significant cardiovascular risk factors. Initially had right occipital lobe infarct. MRA shows stenosis of the right PCA. 6 days later, there were new infarcts. And MRA shows new multifocal stenosis in both the anterior and posterior circulation. 2 days later, some of the vessels showed improvement in the caliber. So is it a case of RCVS or is it a case of vasculitis? Vessel wall imaging was extremely helpful here. It shows concentric thickening of the vessel walls, but importantly, no enhancement. It's a complementary case to the earlier example of vasculitis. No enhancement, concentric thickening is RCVS. And this is our schematic, which we use for our residents. Is there or is there not wall thickening? Is it eccentric or is it concentric? Is there or is there not enhancement and the pattern of enhancement? So this will lead us down the path of the different diagnosis. So in conclusion, vessel wall imaging is time and resource intensive. We don't typically do it in every case of workup, but it's complementary and has very useful with impact on clinical management. These are our references. Thank you very much for your attention.
So thank you for your presentation. And since Mahmoud's mic is not working, so I will conclude this session. So it's all for this session. Hope you all have a good lunch.